surgical ECMO was being used per day. So there was a havoc regarding the massive transfusions. No financial sponsorships. Past experience, as I said, the cardiopulmonary bypass was closely associated with blood transfusion, which has decreased quite a lot. So the plan of this talk is to tell you about blood components, the indications and the contraindications, preparation and administration, and the side effects. We are using the blood in ECMO circuit. We have to see what is used pre-oxygenator and what is used post-oxygenator. Most of the time, we tend to give blood not in the circuit at all, but if it has to be given, then the position would be the whole blood RBCs are to be given, exchange transfers and FFP are to be given pre-oxygenator, and platelet and cryopressor post-oxygenator, but it should be avoided. Blood products. Fresh whole blood. The cellular component is 45%, the plasma component is 55%, the estimated hematocrit is 35%. There are anticoagulations used is CPD, CPD2 or CPD-DA1. It is stored between 1 to 6 degrees centigrade. It should be ideally less than 72 hours old, and it contains platelet, granulocytes, and labile factors also. Packed cell transfusions. It is only cellular component. The estimated hematocrit is 70 to 80%. The anticoagulations are CPD, CPD2D, and CPD-DA1. Stored between 1 to 6 degrees centigrade. Good for 21 days, ideally. Usually it should be less than 11 days, but can be extended up to 42 days. The volume is 250 to 350 cc, and the standard dose is in a pediatric population 10 cc per kg, and the usual range is 5 to 15 cc per kg in children. Adult patients increase the hematocrit by 1.5 hemoglobin % with 1 unit transfusions. So blood products administration. They are required immediately after initiation of ECMO. They may be platelet, packed cells, fresh frozen plasma, or cryo. So for packed cells, it should be transfused when the hematocrit is lower than required. For VA ECMO, it should be above 35%, and VV ECMO it should be above 45%. It contains packed RBCs with a hematocrit of 55 to 70%. It should be given over 1 hour. The dose is for kids around 10 ml per kilogram. The volume is roughly 250 to 300 ml. It should be given from a central line. It increases the hematocrit, and the adjustment of heparin dose is not required. It will have high potassium because the RBC is getting lysed. The acid levels of the CPDs is also giving rise to requirement of soda bicarb, and citrate in the blood reduces the ionic calcium content. For whole blood transfusion, it will increase the hemoglobin clotting factors in the volume. You require the adjustment in the doses. You don't require the adjustment of the doses of heparin. In case of massive transfusion, you can give 1 blood volume in 24 hours. And if you have to take care of potassium, the acid, and the citrate and the calcium levels. For FFP, you have to have the coagulation profile. For fibrinogen less than 100 milligram per deciliter, APT more than 30, APTT more than 250 is the indication for giving FFP. It will dilute your hematocrit. Because it uses citrate as an anticoagulant, it decreases the calcium levels. The primary indication is the replacement of the coagulation factors. It includes water, electrolyte, plasma proteins, globulin, and coagulation proteins. It is stored at -20 to -40 degrees centigrade, and it has to be thawed upon and used within 24 hours. The standard dose is 10 cc per kg or 1 unit per 20 kgs, and it decreases the factor activity by 20%. Cryo. Cryo, it contains factor 1, factor 7, factor 13, 1 million factor fibronectin, and minor amounts of plasma proteins. It is stored and it has to be thawed upon, and it should be given within 4 hours after thawing. The standard dose is 1 unit or per 10 kg or 10 to 15 cc per unit is the preparation, and 1 unit per 10 kg of body weight increase the level of activity by 50 milligram per deciliter. It should be given over 5 minutes. The dose is 10 to 15 ml. The volume is 10 to 15 cc per unit, and it should be given in 4 hours, and it will increase the fibrinogen activity and some clotting factors. And you have to increase the fibrinogen level. 1 unit will increase the fibrinogen level by 50 milligram per deciliter. Adjustment in heparin dose is required. Then platelets can be stored up to 5 days at 20 degrees centigrade. Indications are thrombocytopenia with the platelet count less than 15,000, and a bleeding patient with the platelet count less than 50,000, and for an invasive procedure if the platelet count is less than 50,000. You may use a single donor platelet transfusion that avoids multiple transfusion reactions. The volume is 250 to 400 ml. The dose is around 1 unit for more than 40 kg patient, and 5 to 10 ml per kg if it is a child, and it's stored at room temperature with a shelf life of 5 days. Antithrombin 3 concentrate. It inhibits the thrombin and factor 10A activity and enhances the heparin activity by more than 100 times. You calculate it by measuring the anti-10A levels and for more precise management of heparin levels, and the dosing formula is given by this formula. Granulocyte transfusions, they are prepared at a time of immediate transfusion. The indication is severe neutropenia or with infection, and the patient is in sepsis. The patient is given GCSF and steroids and other supportive agents. The complications are severe allergic reactions, and you can irradiate the granulocytes before transfusing them. The blood product administration can lead to DIC. That is caused by the free thrombin in the blood products with widespread intravascular coagulation, clotting that can lead to organ ischemia. The recognizing signs is Petici, and you have to treat the primary process. If you find organ ischemia, heparin may be used. If it occurs during ECMO, the patient is either under heparinized, and therefore you correct it by correct the bleeding with FFP, cryoprecipitate, platelet, and heparin, and you never turn off the heparin. The washed blood products, they reduce the allergic and side effects of blood transfusions. So RBCs, platelets, and these RBCs and platelets can be washed to decrease the side effects. Leukocyte reduction filters. During a centrifuge, you find some amount of plasma and leukocyte are still there in packed RBCs bags. So you can use the reduction filters or irradiate them or do a double centrifuge. Then transfusion complications. The transfusion complications are acute, chronic, and transfusion-related infections are delayed complications. In acute reactions are hemolytic reactions, acute hemolytic transfusion reaction, febrile non-hemolytic transfusion reactions, allergic reactions, transfusion-related acute lung injury, coagulopathy and massive transfusion, bacteremia, transfusion-related circulatory overload, and transfusion-related hypotension. The frequency of transfusion reactions is acute hemolytic reaction 1 in 25,000, anaphylaxis reaction 1 in 1,50,000, febrile non-hemolytic reactions 1 in 200, allergic reaction 1 in 1,000, delayed hemolytic reactions 1 in 2,500, and that is other things are rare. Acute hemolytic transfusion reactions, they occur with an incompatible RBC mismatch, and it causes an intravascular hemolysis, and the symptom starts within minutes of transfusion, and the volume can be as low as 10 to 15 cc of transfusion. Most common cause is labeling error and can be fatal. Symptoms are high fever, hypotension, abdominal and back pain, oliguria, dyspnea, dark urine, and pallor. Okay, what to do? You stop the transfusion, you get the EVG of the patient, maintain the IV access, monitor and maintain the blood pressure, give diuretic, obtain blood and urine samples for transfusion reaction workup, and send the remaining blood to the blood bank for workup. What is the blood bank workup for acute hemolytic transfusion reaction? You check the paperwork to assure there are no errors, check plasma for hemoglobin, You repeat the cross match, you repeat the blood group typing in the blood culture. Lab findings of AHTR, hemoglobinemia, hemoglobinuria, and hyperbilirubinemia and abnormal DIC level. Monitoring of AHTR, you see the clinical parameters, the vital parameters, the BUN, creatinine, the coagulation profile, and monitor signs of hemolysis by LDH, bilirubin, and haptoglobin levels. Febrile non-hemolytic transfusion reaction. Febrile non-hemolytic transfusion reaction, the definition is the rise of patient temperature by 1 degree centigrade. This is associated with transfusion where without fever or other precipitating factors, it occurs in approximately 1% of PET cell transfusions and 20% with platelet transfusions. They are caused by antibodies directed against the HLA antigens, and we need to evaluate the AHTR and other infection as a differential diagnosis. What to do? You stop transfusion, use antipyretics, steroids, use narcotic for pain and treating side effects. You also consider you prevent future reactions by leukocyte filters. Use only single donor platelets, use fresh platelets, and you use washed RBCs and platelets. Then allergic non-hemolytic transfusion reaction. The etiology may be the plasma proteins in the blood preservatives, and it is seen in patient with IgA given to IgA deficient patient or anti-IgA antibodies during blood transfusions. It presents with urticaria and wheezing. The treatment is for just giving antihistaminics and stop transfusion and may require steroids or epinephrine. Okay. Then transfusion-related acute lung injury. In transfusion-related acute lung injury, it occurs with plasma-containing transfusion, and this causes an antibody in the respiratory membrane leading to pulmonary edema. It presents like a severe respiratory distress, and the treatment is the treatment of ARDS with steroid oxygen therapy and mechanical ventilation. So the clinical syndrome is similar to ARDS. It occurs 1 in 6 after receiving the plasma-containing blood products. It is caused by the white blood cell antibodies present in the donor plasma that results in pulmonary leukostasis, and the treatment is mainly supportive. The mortality is high if not attended, and if it is attended, it has a very good outcome. Then massive transfusion, patients with surgical ECMO and requiring more than 10 units of blood per day because oozing everywhere results into complications of massive transfusion, coagulopathy and electrolyte disturbances and allergic reactions are very common in such cases. Then chronic transfusion reactions, they are autoimmunizations, transfusion associated graft versus host disease, iron overload, and transfusion transmitted infections. Autoimmunization that can occur with erythrocytes and platelets, and the antigen disparity in the erythrocytes and HLA antigens in the platelets result into autoimmunization, which is usually asymptomatic, but it can result in formation of antibodies. Then transfusion associated graft versus host disease. This is seen with bone marrow transplant patients and in infant patients. It results in engraftment of the donor lymphocyte with an immunocompetent donor into an immunocompromised host. The symptoms are diarrhea, rash, skin pancytopenia. Usually it is not fatal, and prevention is by irradiation of the PET cells. Then graft versus host disease, they are basically secondary to the contaminated blood, and they occur more commonly with fresh whole blood transfusions and is the result of donor and recipient HLA types. It occurs 8 to 10 days after transfusion, and in bone marrow aplasia and pancytopenia patients. Then the blood bugs. They are hepatitis C, hepatitis B, HIV, CMV. Parasites. Bacterial contaminations are more common with severe platelet transfusions. The organism can be gram-positive. Staph or strep in RBC, Yersinia, and Enterobacter are commonly seen, and the risk increases as the old blood is used. How to prevent graft versus host disease or infection? There are 4 methods: leukocyte depletion filter, gamma irradiation. You check for CMV virus, double check for the presence of virus infection, and by single donor platelet transfusions. Double centrifugation is a very simple method. The leftover plasma and the leukocytes can be separated from the PET cell transfusion by double centrifuge, which can be easily done. Okay. Uh, the management of prevention of no, this is not the right slide. Anyway, so for transfusion related acute lung injury, I told you the management is mainly the management of ARDS. For massive transfusion, you have to take preventive steps. Then transfusion related circulatory overload is the result of when you use fresh blood and the plasma and the volume gets overloaded. So the management is like any other cardiac, low cardiac output state, or like a circulatory overload with the diuretics and oxygen therapy. Then transfusion related hypotension, the cause is not known and other causes has to be ruled out, but you have to treat them like a circulatory overload or like correction of the gas levels and the correction of the blood pressure by inotropes. So that helps. So basically, in blood products, if it is a medical ECMO where you are not using a knife, then the blood requirement is hardly 1 to 2, not even 1 unit per day or less than 1 unit per day. If it is a central cannulation or a post-surgery ECMO, the blood requirement can vary between 5 to 10 units per day, and that is where the real problem of blood transfusion comes up. And preventive role is very important. Your own blood bank, who is very much methodical and meticulous about preparing fresh blood and taking all the precautions, is the only way to prevent the complications of blood transfusions. Usually they are comorbid conditions which add to the deteriorating condition of the patient. So, and they are invariable, means if the patient is losing blood, you have to build up the blood levels, and in that 11th hour you may not get the right blood. So that catch 11 situation is a problem. You are not having all the blood for a bleeding patient. Thus, take home message is that the transfusion reactions, the ASTR, can be fatal. You have to stop the transfusion as soon as you see any complication. You monitor for the symptoms, and complete evaluation of the patient is required. For febrile non-hemolytic transfusion reaction, there is a diagnosis of exclusion. For ARDS-like situation of transfusion-related acute lung injury, the management is like ARDS. For chronic transfusion reaction, prevention is the best aspect. and using filter, irradiation, double filtration, and pre-medication is the answer. Thank you.